So you are live now, ma'am.
Good morning and a very warm welcome to the 5th Glaucoma Crescendo, the international webinar of the Glaucoma Society of India. This morning, we have none other than Professor W.H. Morgan as our guest speaker, and he will be introduced in a moment's time by our President, Dr. S.S. Pandav. Before I hand it over to Dr. Pandav, I'd like to introduce our expert panel this morning. We have with us Dr. Barun K. Nayak. He's the head of the Department of Ophthalmology at the PD Hinduja Hospital and MRC, presently the president of the All India Ophthalmological Society and my predecessor as the secretary of the Glaucoma Society of India. A very warm welcome to you, Dr. Nayak.
Thank you.
Dr. Shushmita Kaushik, professor at Advanced Eye Center, Postgraduate Institute of Medical Education and Research, Chandigarh, ex-honorary secretary of the Glaucoma Society of India. A very warm welcome to you, Dr. Shushmita. Unfortunately, this morning we don't have with us Dr. Satyan Parthasarathi. He had a bereavement in the family this morning, and suddenly that's why he could not join us. Next, we move on to Dr. Sati Devi. Dr. Sati Devi is the head of glaucoma services at the Narayan Netralaya 1 at Bangalore. A very warm welcome to you, Dr. Sati. Dr. Rakesh Saikia, consultant glaucoma and cataract service, Sadguru Netra Chikitsalaya, Chitrakoot. A very warm welcome to you, Dr. Rakesh. Dr. Pallavi Raj, senior consultant, glaucoma and cataract services, Shankara Netralaya, Kolkata. A very warm welcome to you, Dr. Pallavi. And we have with us our treasurer, Dr. Mayuri Khamar. Very warm welcome to you, Mayuri Ben. So with that, I hand over to our president, Dr. S.S. Pandav, to kindly introduce this morning's guest speaker. Over to you, Dr. Pandav.
Thank you, Dr. Nirma. It's indeed a great pleasure for me today to welcome Professor W.H. Morgan, Bill Morgan, who is also my mentor. And Professor Morgan is a professor at University of Western Australia. He is former head of department at Royal Perth Hospital, and currently he is managing director of the Lions Eye Institute. Lions Eye Institute is said to be the biggest research facility in the Southern Hemisphere. He is also visiting professor at the Udayana University, Indonesia, and has been chairman of the NHMRC Glaucoma Guidelines Committee for the Australia. Professor Morgan is an inventor and a keen researcher, and I'm sure most of you already know him because he is the inventor of the Zen implant, which has become quite popular in many countries. In India, we don't have it yet, but I think a lot of Western countries and America, they are using this implant with good results. He also developed a low-cost GDD, I believe, for Indonesia, and if I'm not mistaken, is called Vernaim GDD or something like that. So that was kind of a, because GDDs are very expensive, so he developed a low-cost GDD, which is being used in Indonesia now. He has a lot of interest in optic nerve, how it responds to pressure, particularly in relation to glaucoma. And he actually in the early 90s or mid 90s, he developed this concept of translaminar pressure gradient across the lamina cabrosa in relation to glaucoma. And he has several publications, in this field, like influence of CSF on lamina cabrosa, the optic disc movement in relation to pressure gradient in the CSF, retinal venous pulsations in glaucoma and glaucoma suspects. And he also have done extensive work on retinal ganglion cell energetics, their metabolism, the exon transport, and cytoskeletal changes in relation to glaucoma and elevated intraocular pressure. Above all, Bill is an excellent human being, a very passionate, person, and he has a lot of passion for community work. And he regularly visits regional hospitals at Albany. And I remember going with him once to the Kalgoorlie gold fields. There are no gold now there, but there are a lot of indigenous population who still resides there. And he has been visiting them regularly, almost every year, once a year, to look after their health, eye health for those people. And I saw at that time his passion for working with those communities and helping out them. Today, we are very fortunate to have him with us, and once again, on behalf of Glaucoma Society of India, I extend a very warm welcome to you, Dr. Morgan, for spending your time with us, and also thank you for being with us this morning. Dr. Morgan is going to speak on how does glaucoma occur and what makes it worse. So that's again a very interesting and fascinating topic, and probably this will include all of his research that he has been doing in the past several decades, and I'm sure we'll all be benefited by the experience and the work that he has done. Over to you, Bill. Thank you so much for joining us this morning.
Thank you very much, Surinder. Thank you very much for that very kind introduction. And I have to say, I'd much rather be with you in India. I love coming to India. So it's just an incredible and amazing country. I thought I would talk about how does glaucoma occur and what makes it worse from a kind of pressure mechanical point of view. So it really follows on and includes work that, as Surinder said, I started about 25 years ago, looking at the pressure gradients across the optic nerve. We all know pretty much what glaucoma is. It's generally involved with altered pressure, a high elevated intraocular pressure commonly, but it's really a disease which causes a classic change in the optic nerve. It's often associated with disc rim hemorrhages. And in many ways, it's the opposite to raised intracranial pressure, papilledema effects upon the nerve, where with one condition, that's the raised CSF pressure, you get forwards movement of the optic nerve tissues. But when you have glaucoma, you get backwards distortion of the optic nerve tissues. And indeed, the intraocular pressure is the major risk factor for predicting glaucoma occurrence. And this quite famous piece of work published 30 years ago now was the first piece of work to describe the exponential relationship between intraocular pressure and the relative risk of developing glaucoma or progression, in this case at 4 years following the intraocular pressure measurements. So you'll see that the pressure, when you have a pressure in excess of 30, you're more than 40 times more likely to get glaucoma than somebody with a pressure less than 16. And you'll see that that relationship is not linear, it's actually exponential. We do know that glaucoma, the relationship between pressure and glaucoma is not straightforward, and that if you take a bunch of normal subjects, in this case from 2 Welsh villages back in 1966, in this seminal study by Hollows and Graham, that the median intraocular pressure is between 15 and 16 millimeters of mercury, and that the normal range, or 95% of measurements, go between about 10 and 21 millimeters of mercury. But when you have glaucoma without treatment, some 2/3 of those glaucoma patients will have pressures greater than 21, along with a lot of normal subjects. But interestingly, about 1/3 of glaucoma patients will have pressures less than 21. So this observation back in 1966 really changed the paradigm for thinking about glaucoma from being just a disease of high pressure to being one of an optic neuropathy where pressure was a risk factor. So looking at other risk factors, the early manifest glaucoma treatment trial, which was published more than 20 years ago, demonstrated that for every millimeter pressure rise, there was approximately an 11% elevated risk of progression, and that was an exponential function again, a little bit like the work by Sommer published 10 years prior. The other major risk factors in a Caucasian population in Sweden were disc rim hemorrhages and pseudoexfoliation, and also, interestingly, a thinner cornea. Some other factors by other studies were noted, such as race and heredity, and we'll just briefly touch on that. But I thought I'd show you this graph of a typical intraocular pressure versus relative risk profile. And you'll look at the color bars on the right-hand side, and just remember the early manifest glaucoma treatment trial was 11% increase per millimeter mercury. So that line for the EMG-TT study is between the yellow and the green lines, which shows you the exponential nature of that function. The shape is very similar to the work published by Sommer. So in fact, every patient that we see with glaucoma is sitting somewhere on one of these lines. And the whole reason, the whole treatment paradigm for glaucoma at the moment is basically to shift, supposing a patient is on the green line, is to basically shift that patient's risk profile down the green line. And the only way we can do that is by lowering the intraocular pressure. Now, different patients may be on different lines. We may have somebody with a more robust optic nerve head on this red line, so that their relative risk of progression is relatively low. Alternatively, we may have a patient on this orange line with a very high, what I would call risk curve or risk profile. And I'll give you some examples of these patients that we all know about. For example, patients with high myopia, for example, tend to be on a high risk profile curve. That is, they're more fragile. So it would be nice if we could actually flatten the curve and not only shift the patient towards the left by lowering their intraocular pressure, but actually flatten the curve. But in order to do that, I think we have to understand why those curves change in the first place. Now, just getting back to race, so unfortunately, some races are more susceptible to glaucoma, which indicates a genetic predisposition. So you'll see here, this is quite a nice summary data published from a review article I found. And unfortunately, particularly West Africans, the black populations in the United States, for example, are the highest risk. And for some unknown reason, Caucasian populations are at lower risk, but still at risk of developing glaucoma. Just to briefly review the histological features of glaucoma, and it's worth noting that from the left, we have a juicy, thick nerve tissue with a plump appearance to the optic nerve. And as glaucoma develops, we get effacement and thinning of the nerve fiber layer and some shift of the tissue backwards and outwards. And then finally, in severe glaucoma, where we have very definite excavation, we have a shift of the tissue. And here, I've forgotten to mention the presence of the optic nerve subarachnoid space. And you can see that normally there's a reasonable gap between the optic nerve subarachnoid space and the vitreous, which is where the intraocular pressure is having its principal effect. And that gap is normally about 1 millimeter. So it's not very large. And in fact, I'll show you some other data in a minute, the actual distance between the pressure boundaries is actually less than that. But when you have severe glaucoma, the first thing you'll notice is how the tissue is being pushed towards the optic nerve subarachnoid space. It's almost acting like a suction effect, pulling the tissue towards it and tending to compress it in that direction. And you can see this on OCT scanning with excavation as well. The effects of the damage to the nerve are quite apparent to see. One can see going from normal to more severe glaucoma with some excavation here and a disc rim hemorrhage, to finally moderately severe glaucoma with the changes in the visual field secondary to the loss of the ganglion cell axons. It's been conjectured for a long time where the primary insult occurs, and this is probably the most definitive study, published back in 1976, so about 45 years ago, by a very famous Czech pathologist who found that one gets axonotmesis, that is interruption of the axons, at the level of the lamina cribrosa, particularly the posterior lamina cribrosa in humans. And one also gets attempts at regrowth or sprouting. And you can see these bulbous extensions of the axons that have been interrupted in this patient with glaucoma, but the resprouts don't grow very far and they soon die off. And then you get retrograde death flowing back to the cell bodies in the retina with apoptosis. So it's a process with the primary interruption occurring at the lamina cribrosa. So that's where the damage is occurring, and then everything occurs secondarily after that. Finally, in terms of the clinical spectrum, I thought I'd show you this curve, which illustrates why it's often difficult to diagnose glaucoma and to detect progression. So this is the relationship between the neuroretinal rim area based on HRT scan measurements and also the mean deviation, so the field loss. And you'll see there's not a linear relationship. And in fact, you need to lose almost 50% of the typical neuroretinal rim area before, on average, you get a 4 decibel drop in visual field mean deviation, which is about the threshold at which it's possible to detect a visual field change. So the problem often with glaucoma is that we don't definitively diagnose it until quite a lot of damage has been done, not just to the nerve tissue, but also to the connective tissue underneath. So just harking back to the physiological problem of glaucoma, so the glaucoma, in terms of its pressure effect, we hypothesized that it's likely to be, in fact, a pressure gradient problem across the lamina cribrosa, having a whole range of secondary effects upon the nerve tissue, the connective tissue, and the blood vessels themselves, which then leads to this classic excavated picture here. So we started these experiments in the 1990s, and we used the dog as our model because they have an eye that's similar size to a human. And you'll see here, this is a micropipette which has been passed into the eye with a special robotic control system, and it's measuring pressure as it goes from the vitreous through into the optic nerve, into the laminar tissue, and then the retrolaminar tissue. We get these typical curves, and you'll see the pulse of the cardiac cycle causing this sort of regular pulsation. And you'll see as we enter the prelaminar tissue, the pressure stays roughly constant, so at intraocular pressure levels. Then as we start going through the lamina cribrosa, the tissue pressure drops until we reach the retrolaminar tissue, at which it stays relatively constant. And in these experiments, we measured intraocular pressure, which is this line here, as well as the CSF pressure, so we could get a gauge on both. This is the typical profile we would get from one animal, where you can see if we started with a high intraocular pressure of 35, then the gradient across the lamina was much steeper than if we started with your typical intraocular pressure of 15, when the gradient was much less steep. And we could calculate using standard linear regression the actual gradient. So here, when the dog's intraocular pressure was 15 and the CSF pressure was 0, the gradient was about 30 millimeters of mercury per millimeter of tissue, but it went up to over 100 millimeters of mercury per millimeter tissue at the higher intraocular pressures. It's also worth noting that the pressure in the retrolaminar tissue did not reach zero, even when CSF pressure was zero. So it reached on average about 4 millimeters of mercury when the CSF pressure was zero. And this was very consistent across the animals. So it was telling us that there may be some buffering effect occurring, which is tending to keep the retrolaminar tissue a bit above CSF pressure in some circumstances. And we'll discuss that in a minute. So typically what we did find in the dog was that the lamina was about 0.5 millimeters thick, and that the gradient was occurring and was limited to occurring across the lamina cribrosa. Of course, we wanted to know what was occurring in the human, so in our patients, but clearly we can't do these experiments in patients. And Dr. Pandab was involved in these later experiments where we did histology, and we actually measured all of the physical characteristics of the dog tissue and a range of human optic nerves that we were able to access. We compared the connective tissue measurements of the lamina cribrosa and also the pia mater thickness characteristics. And we, using some physical principles, calculated that typically when the CSF pressure is 15, the intraocular pressure is 15, CSF pressure is 0, you get either about 20 millimeters of mercury per millimeter or 33 millimeters of mercury per millimeter, depending upon whether you use what we call the whole lamina cribrosa measurement or simply the scleral lamina, so the collagenous lamina and not the glial lamina tissue as your reference. There's actually theoretical reasons to presume that the scleral or collagenous lamina is the main reference to use here. Now, as we were doing this sort of work, Jos Jonas in Germany was interested in the relationship between the CSF space and the intraocular pressure, but also what was happening to the lamina cribrosa. And he did histological studies on many eyes and found that in the humans, typically your lamina is about 460 microns in thickness, so almost half a millimeter. But when you've had glaucoma for some length of time, it becomes compressed and thins to about 200 microns. And in fact, if you are a myope, your normal laminar thickness is only about 200 microns. So you start off with a much thinner lamina cribrosa than if you are not a myope. And that if you are a myope, a high myope with advanced or moderate glaucoma, your lamina will be compressed and thinned even more, down to about 80 microns, which is incredibly thin. So let's have a think about this. Does the actual gradient across the lamina cribrosa matter? What effects may it cause? Well, from other work we did in the laboratory looking at donor human eyes, we found that, in fact, the vessels, particularly the veins in the optic nerve, so the centroretinal vein, as it passes across the optic nerve, acts as a type of barometer on the hemodynamics or the pressure flow relationships occurring in that part of the eye. So normally in the arterial system, when one looks at the endothelial cells, we see spindle-shaped cells that have changed their shape to handle the high velocities and the high shear stresses. When you look at veins, when the velocities are generally much slower, the vein endothelial cell is more polygonal, it's sort of plumper and fatter. However, in the collagenous lamina region of the human eye, the vein endothelial cells are shaped exactly like an arterial cell, endothelial cell. They're long and spindly shaped, whereas the glial lamina region is polygonal and the retrolamina region is polygonal. So this added to our assumption that in fact the collagenous lamina is probably the region where the gradient is occurring in the human. Now, why do we worry about the gradient? Well, if you have a high pressure gradient, axonal transport, which is a vital physiological phenomenon occurring in nerves to supply energy and mitochondria to regions where energy is required, you can see the mitochondria being transported here in a normal nerve. That process must continue occurring in the ganglion cells, and it can be inhibited, or rather it will be inhibited, by pressure gradients in excess of 45 millimeters mercury per millimeter distance. This is the summary of our published results measuring the gradients in the dogs, and this is the relationship between translaminar pressure gradient on the y-axis versus the difference between intraocular pressure and CSF pressure on the x-axis. Now, we did graph these against just intraocular pressure and also just CSF pressure, but by far the strongest linear relationship was when we used the difference between intraocular pressure and CSF pressure on the x-axis. And you'll see that when intraocular pressure was 16, CSF pressure 0, which is typical for a human, the translaminar pressure gradient was about 25 millimeters of mercury per millimeter tissue. When the intraocular pressure goes in excess of 25 millimeters of mercury, that gradient started to go up, and it was in fact in excess of 45 millimeters of mercury per millimeter of tissue in somebody with a healthy lamina cribrosa. What else can happen? Other authors have published on the axonal transport inhibition in the optic nerve when you elevate intraocular pressure. We did these experiments using the pig, and on the left-hand side, the normal intraocular pressure 13, you can see that the tracer dye injected into the vitreous has been transported back, far back into the optic nerve by 6 hours or by 12 hours. Whereas in a pig with an intraocular pressure of 43, the tracer dye is held up and inhibited from being transported across the lamina cribrosa. It's just getting into the retrolaminar tissue at 12 hours, but not much further beyond that. And also, if you stain for COX-2, that's cytochrome oxidase, a vital component of mitochondrial metabolism, you'll see that there's much higher staining in the laminar region. So this brown is much brighter in the laminar region, telling you that the mitochondria there are having to work much harder to produce energy for all the little motors, the dynein and kinesin motors that attach to the mitochondria and other vesicles and enable them to be transported down the axons, compared to the normal intraocular pressure, which has a slightly higher density of stain compared to the prelaminar region, but that contrast is nowhere near what occurs when you elevate intraocular pressure. So we've talked quite a lot about theory. I'm going to now put some numbers up that hopefully put this into a clinical perspective. So let's say we have our typical patient who might have a family history of glaucoma, comes to see us with a pressure of 15. And we know on average, a human when they're sitting or standing at eye level has a CSF pressure of 0. So we can reasonably predict from our modelling work and measurements that they'll have a retrolaminar tissue pressure of about 4 to 5 millimeters of mercury. So in that situation, they'll have a gradient of about 20 millimeters of mercury per millimeter tissue across the whole band of the lamina. Now, let's suppose over the next 5 or 10 years, the pressure rises to become 25 millimeters of mercury. As it does so, the gradient becomes steeper and in fact doubles to be 40 millimeters of mercury per millimeter of tissue. Let's suppose that they don't see an eye doctor or a specialist and they're undiagnosed for quite some time. And over time, the lamina cribrosa starts to compress and thin. And you'll see here, the black dots represent early on in the piece when the lamina is still thick and juicy. But as time progresses, the lamina will tend to collapse or compress along the lines of this blue arrow. And as it does so, it amplifies the gradient. So the pressure difference is now occurring over not 500 microns of tissue, but about 250 or 300 microns of tissue. And the gradient is now doubled because of that effect to become 80 millimeters of mercury per millimeter of tissue. So now we start to see effects upon axonal transport, vessel effects, which I haven't gone into, changes in the cytoskeleton, which I haven't gone into, and more changes in the connective tissue. Okay, so the patient then sees an ophthalmologist who detects changes in their nerve as well as the higher pressure and realizes they have glaucoma. So the pressure there, of course, is 25 millimeters of mercury, and we put them on a drop or treat them, and we reduce the pressure down to 15. And we think to ourselves, that's fantastic. We've normalized their intraocular pressure. But one of the key questions, perhaps the main question, is, have we in fact normalized their translaminar pressure gradient? Now, the problem is we have not, because the lamina cribrosa still remains thinned. We don't have a way of re-expanding it or strengthening it. So we have reduced the gradient from 80 down to 40 millimeters of mercury per millimeter, but it still remains somewhat elevated. So in a nutshell, that's one of the problems we face with glaucoma, is that we think we're doing a great job, but we don't really know what changes have occurred to the underlying optic nerve tissue. And almost certainly it involves more than just laminar thickness. It probably involves features to do with mitochondrial health, cytoskeletal health, and also vascular, particularly venous changes that we've started exploring in recent years. I'll touch on a few things that can happen as you alter both intraocular pressure and CSF pressure. We did these series of experiments many years ago when confocal scanning laser ophthalmoscopy had just become available. Again, we used the dog. We cannulated the lateral ventricles and the eye, and we took images of the surface position of the optic nerve. And in summary, this graph is what was the outcome of those experiments, where we found that most of the movement of the optic nerve was dependent again on the difference between intraocular pressure and CSF pressure, not just intraocular pressure and not just CSF pressure, but the difference between both of them. And that most of this movement occurred between very low intraocular pressure, CSF pressure differences of about 2 up to about 15 millimeters of mercury difference. And then when you elevated the gradient beyond that, you didn't actually get much more movement. There was an old theory for glaucoma causation that posited that the damage to the nerves was due to shearing and movement of the lamina cribrosa. But this work and other work like this have really eliminated that as the cause, because we know that glaucoma is much more likely to happen when the pressure gradient is well in excess of 15 or 20 millimeters of mercury, not at the lower ranges. What this work did show is that we need to take into account changes in the translaminar pressure difference when we're thinking about interpreting changes in the neuroretinal rim appearance or the surface appearance of the optic nerve. More recently, in about 2008, a group from the Mayo Clinic, who had access to computerized files there and patients who'd had lumbar punctures for both reasons of and who also had glaucoma for various reasons, were examined. What they did find was that patients with glaucoma tended to have a lower CSF pressure than normal subjects, here about 9.6 millimeters of mercury compared to 12.7, and that patients with so-called normal pressure glaucoma had even lower CSF pressure. This was borne out in a prospective trial in China with similar, if you like, changes or differences in CSF pressure, where the CSF pressure in the normal group was about 13 millimeters of mercury, and in the glaucoma group was 9.5 millimeters of mercury. So not huge differences, but significant differences in CSF pressure. There's been quite a lot of work, not by our group, but by other groups, mainly in Canada and the United States, looking at modelling the stresses on the optic nerve and where they might occur as intraocular pressure is elevated. And I just point out this one area of the photograph showing much heightened stresses and strains in the region of the sclera directly adjacent to the lamina cribrosa, in the posterior lamina cribrosa. So this region here, and also in the posterior lamina cribrosa, right up against the optic nerve subarachnoid space. So you'll see the strain on the left and the stresses on the right directly abut the optic nerve subarachnoid space here. And they partly explain why one sees excavation. It's almost as if the optic nerve subarachnoid space is pulling that tissue in towards it. We can see this on OCT scanning, and here, if one imagines the results of those modelling experiments, where unfortunately the OCT scan does not always project right the way through the tissue because the overlying tissue is thicker and you get this sort of blockage of the light transmitting through. But I've just drew this diagram to illustrate in a patient with excavation where the optic nerve subarachnoid space may lie and where the zone of principal stresses and strains may well be, and that this highlights why one sees excavation. Now, we don't always see large amounts of excavation, and there's a reason for that. Oh, I thought I was going to, hang on. Oh, here we go. I thought I'd skipped a slide. This is OCT scanning through a patient with high myopia from our clinic. This idea was actually first described by a Japanese group about 10 years ago using the first versions of swept source OCT. But you can often actually see it with high penetrance OCT, so the standard Heidelberg spectralis. You will get images like this. This is from a swept source that we borrowed for a short length of time about 7 years ago. And this is a patient with high myopia. And you can actually see the optic nerve subarachnoid space here. It's very clearly visible. And you'll actually see the above deformation of the retinal surface in a classic posterior staphyloma. What the Japanese group realized was that under virtually all the posterior staphylomata that they could image, there was a very much broadened, expanded optic nerve subarachnoid space, again acting like a suction zone, sucking down the retina in this case. Whereas normally the optic nerve subarachnoid space is much thinner and really has a restricted area of influence, more directed at the optic nerve. But in a high myope, I've drawn the zones of likely forces and stresses here. So unfortunately, in a high myope, not only have you got zones of force acting across the optic nerve into this zone of the optic nerve subarachnoid space, but you've got it acting across a broader range of the retina and that very thin scleral region which surrounds the optic nerve. And the fact that you've got this sort of blending of a weakened sclera next to a weak lamina means that you don't have such a distinction between the two, and excavation is not so prominent. So it can be more difficult to detect excavation in high myopia in particular, and yet they're still much more susceptible towards getting glaucoma. Let's talk about the CSF pressure and its effects in a little bit of more detail. And here I've just wanted to show you this picture. We're talking about buffering effects potentially of pressures upon the retrolaminar tissue pressure. So in those experimental series using the dogs, I was able to cannulate the lateral ventricles, and here you'll see the lateral ventricle pressure as these open white circles. So comparing lateral ventricle pressure to the pressure measurement per se. And I was able to, in a number of the dogs, get the pipette into the optic nerve subarachnoid space and measure the pressure. And you'll see that if you started at a higher CSF pressure and then reduced it, the optic nerve subarachnoid pressure was identical to lateral ventricle pressure until you got down towards 0, which is, remember, that's your normal CSF pressure when you're sitting and standing for a human. And then there was a separation that was occurring where the optic nerve subarachnoid space pressure did not change very much, even though the lateral ventricle pressure continued to fall. In another series of experiments, I was actually able to cannulate, go across the pia mater. So I made a hole in the dura and passed the pipette sideways across the pia mater using a lateral orbitotomy approach, and found that the retrolaminar tissue pressure was even higher, and that it started to form what we called a floor at about a CSF pressure of 4 millimeters of mercury. So you've got two zones of pressure discontinuity. And what we've realized is that the difference between optic nerve sheath pressure and the retrolaminar tissue pressure is caused by pia mater elasticity. And another series of experiments we performed demonstrated that. But also, there's something causing a relative stability of the optic nerve subarachnoid space pressure. And that's almost certainly the orbital pressure. But it's very difficult to measure orbital pressure and optic nerve subarachnoid space pressure at the same time. So unfortunately, we've not been able to experimentally confirm this, but we cannot think of any other explanation. So we've come up with what we called a 4-compartment model to explain the pressure bearing upon the retrolaminar tissue pressure. So the major influence is the intracranial pressure, which passes forwards along the optic nerve subarachnoid space, but it has to act across the pia mater. And so that becomes one of the buffering zones. And if you're lying down where you have an elevated cranial CSF pressure, that's fine. The fluid is tending to move and push itself into the optic nerve subarachnoid space. But if you're standing up or sitting, then the cranial CSF pressure becomes 0 or even lower than 0. And in effect, it's sucking the fluid out of the optic nerve subarachnoid space. And then what bears upon the pia mater more directly is the orbital pressure. So these two pressures become significant, and they act as a buffer, and they probably explain why it's not quite clear-cut that a low CSF pressure always leads to glaucoma, because we have these buffering effects occurring as well, which we cannot measure. We can't measure CSF pressure in most people. Oops. Oh, 1 second. Oh, here we go. Oh, sorry. And I just wanted to mention this because there are certain drugs which amplify the orbital atrophy effect as a patient ages. The prostaglandins, particularly one of the prostaglandins, can cause optic fat atrophy. And also, as our patients get older, the orbit tends to atrophy, and giving us the clue or the information that the orbital pressure is reducing. So it's tending to inhibit that buffering effect and probably aggravating the gradient occurring across the lamina into the retrolaminar tissue space. So it's very difficult to prove this at the moment because we don't have ways of measuring orbital pressure reliably. So just going back to, if you like, fragility curves, what I call fragility curves, that relationship between change in pressure versus relative risk of progression. So you can see as the disease progresses, as the lamina cribrosa thins, we go from typically a curve between the yellow and the green towards this orange curve with a much higher risk profile per change in pressure. It would be lovely if we could reverse that process, but at the moment we don't have a way of doing so. However, if we're able to expand our physiological understandings of what is going on, then in the future we may be able to do so. So I thought my key points today are that the intraocular pressure and the CSF pressure together help determine the pressure gradient across the lamina cribrosa, and that this is very important in terms of affecting the stress upon the nerves, the energy use, so the mitochondrial activity and requirements, axonal transport, and the optic nerve tissue movement. However, the CSF pressure is not so simple as intraocular pressure. Its effect upon the retrolaminar tissue pressure is modulated by the pia mater and orbital properties. So it makes it more complicated. Also, lamina cribrosa and other optic nerve properties almost certainly influence the shape of that risk intraocular pressure curve. And I try and imagine that curve whenever I'm seeing patients and imagine where they are on their particular curve. I'm going to finish here. Thank you very, very much for listening to me. Thanks very much, Surinder.
Thank you very much, Dr. Morgan. That was indeed a very informative and interesting talk. We actually treat glaucoma as clinicians, but rarely do we trace down right to the pathological level to see how much actually we can do for a patient, tracing it down right to the pathological changes which take place on an individual basis. And I'm sure everybody learned something from your talk today. And I would request Dr. Pandav to start the panel discussion.
Thank you, Chandrima. Thank you, Dr. Bill. I think that was a great presentation. And we have just seen, the glimpse of, I would say, is a snapshot of the enormous work that Bill has been doing over, several years, probably 25, 30 years now. And I think you from this lecture get an idea, how much has gone into all the research that he has done. This is something which is very unique to his work. What I understand, grossly, that the eye is not just in isolation; it's in the pressure compartments. And we knew earlier that there's a intraocular pressure compartment, and then later on we started talking about the CSF, pressure. But I think Bill has told about more pressure compartments now that we have acronoid space, we have the pia mater there, and we also have an orbital pressure. So I think the interplay of all these pressures compartment is what probably determines the occurrence or susceptibility to glaucoma. But I think, as Bill said, we don't understand everything as of now. But I'm sure we'll hear more from Bill in coming years, and we'll have something which is more clinically applicable. So, Bill, how are you using these concepts clinically? How does it make a difference to your day-to-day practice?
Yeah, that's a good question. At the moment, Surinder, we're working on a way of non-invasively measuring CSF pressure using properties of the retinal venous pulsation, which we can measure. That's an area for a whole nother talk. But if one could measure the CSF pressure, also more recently we've been measuring the lamina cribrosa thickness using OCT scanning, which is not as accurate as I would like it to be. But I think in the future we are likely to have ways of measuring both the lamina cribrosa thickness and also CSF pressure. And then we can start to get a handle on the gradient and how it's working in individual patients. So that's where I'm working towards at the moment. In terms of day-to-day clinical practice, I find that I often actually draw that curve for individual patients to explain to them the nature of the disease. And it does help me and help them get a better understanding of why we do certain things, such as lowering their intraocular pressure. Some patients who are on Lumigan, that prostaglandin that can cause a lot of orbital atrophy, if they're young patients, for example, I'll take them off that because I'm just concerned about altering their buffering characteristics. Even though I don't have proof, it would be a lot of fun to do a visual field progression study looking at patients who are on different forms of medication at identical intraocular pressures to see what differences may be occurring related to their treatments and whether, for example, degrees of optic atrophy, orbital atrophy, sorry, not optic atrophy, are impacting. So I don't have it hasn't, if you like, transformed my clinical practice. It probably has altered the way I speak with patients and inform them of what's going on, which I think helps their compliance. Yeah.
I think, you mentioned that the thickness of the lamina cribrosa actually plays in some important role in this process. In glaucoma patients, it goes down, is thinner. In myopia, it's thinner to begin with. Is there any age-related iteration, like it, even in the normal aging, does it lead to like thinning of the optic nerve even in a normal healthy individual over a period of time, which would make the person more susceptible later on?
Yeah, not that I'm aware of. All of the measurements of laminar thickness have come from histological measurements, so people who've died. So most of them are elderly. We don't get many young ones, and we don't get much tissue to look at in any event. So to my knowledge, no one's been able to get enough data to look at an age effect. I think the assumption is that it probably does not have much effect on laminar thickness because older people can still have quite thick laminar cribrosi. And the other issue is that OCT scanning can detect the anterior surface of the collagenous lamina, but not the posterior boundary very well. So we don't have very accurate ways of measuring laminar thickness non-invasively. So that's a limitation as well.
So does the shape of the lamina would give some indications, like flat, or it's kind of becoming concave anteriorly?
Yeah, that's a terrific question. I think that the work from Claude Burgoyne, his group and others would suggest that, well, for a long time we've known that the shape does change. It becomes more concave. Also, the insertion point into the sclera shifts posteriorly as those stresses in that region change. So you can see that on OCT scanning, actually, and you can actually see breaks in the laminar attachment at the sclera. So there's some nice papers out there. We published one on that area, but there are earlier, we were interested in the relationship between laminar cribrosa breaks and optic disc rim hemorrhage, because that's a theory for both causation of nerve damage, but also for the disc rim hemorrhages you see. But the story there is quite complex. It's not a clear-cut story, but definitely you can see laminar breaks and the lamina shifting posteriorly, its insertion into the sclera. So you can actually see some of those changes. Yeah.
Any other question from the panelists? Varun, do you have any?
No, basically, it's thank you very much. And it was a lovely talk by Bill Morgan, and so at least giving us some insight on some research, what is going on so far as the pressure gradients are concerned across lamina cribrosa and the various compartments. So I am sure today, because if the research is going on in that direction, then one day or other, the two things which is essential for clinical practice. One is that how to measure these pressure gradients non-invasively and conveniently and accurately. And the second, that how to modify these, because unless we are able to modify that, we won't be able to, even if we measure it, but we cannot do it. Simply we can explain to the patient, oh, this is happening, but we cannot do anything. So I'm sure maybe in future he will come out with some solution to this, and it was really fantastic talk. So I must congratulate him on the thought process and the time that he is devoting to this. It's basically all dedication which ultimately lead us somewhere positively. Thank you.
Bill, you might remember Varun was actually at Royal Perth Hospital, I think before me.
Oh, right.
I was with Professor Ian Constable, and that time Lions Eye Institute had just started in Charles Gardner Hospital.
Oh.
Yes. That time it had just started, because then I think David Cooper was there and Constable was there. So that was and even the one who is the cataract surgeon.
Oh, Graham Barrett. Probably.
Graham Barrett, yes, he was just, I was following him before he left for US for a short training. So I just followed him.
Oh, that's fantastic. Gee, that's
yes, I actually wanted to visit once Lions Eye Institute, because I had so much fond memories of that place and experiences. So definitely I want to come back sometimes and meet you all there.
Well, we'd love to have you, and anyone is welcome to come. We'd love to show you around.
But Varun is the president of the All India Ophthalmologist Society now.
Oh, right.
I'm sure he'll extend an invitation to you for the next AIU's conference as well.
We will extend one for the GSI as well.
Unfortunately, this year we couldn't have the physical conference, but of the All India Ophthalmic Society. So I had in mind that someone researcher who agrees to come to as my personal guest. So in that case, probably I even asked Pandav. Then he said, yes, Bill Morgan, you can definitely invite. But unfortunately, the thing didn't materialize because there was no physical conference. So it's unfortunate on our part.
Okay, so coming back to the topic. I think what we have, so Bill, you said, I think you showed that graph, where you had that the laminar movement. It happens at the low ranges of IOPs. I think once you go to 15, 20 millimeters of mercury, there's hardly any movement.
Yes.
So is that lower range of IOP movement is a good thing or is a bad thing? I mean, does that suggest that there's some kind of a buffering happens to dampen the IOP or protection mechanism, and once you go beyond 15 or 20 millimeters of mercury, that there's no mechanism to dampen those, the pressure kind of changes across the lamina gangrenosum. So how do we look at it from clinical point of view?
Yeah, that's a nice question. I think that it is a good thing that the lamina is able to move and respond to the changes in the pressure. And it's a very dynamic region as well. So one has to imagine that every pulse beat, you're getting a pulse change in intraocular pressure of about 2 millimeters of mercury, and the CSF pressure is changing by about 3 millimeters. So it's a very dynamic situation where the lamina is probably always moving a little bit. And then once you exceed pressures of 15 to 20, it's unable to move. I'm not convinced it's necessarily the lack of movement that's the problem, but rather the sheer presence of the forces acting across the lamina against which the various motors have to work to shunt little rail loads of vesicles, mitochondria, etc., up and down the line. I think that's the real problem for the optic nerve when the pressure gradients are high. So it's a bit like one of us working to push a truck with coal. It's all right on the flat, on the railway line, but once it gets steeper and we have to push so hard, at some point we don't have the strength to be able to push it uphill. And at that point, in an individual, I think we're getting problems, and then the nerve breaks down and it becomes interrupted, and then you get the whole sequence. And allied with that, you're getting the parallel connective tissue changes and vascular changes too. So, my bias is to think of glaucoma in mechanical terms, with a whole lot of effects occurring consequent to the pressure gradient. I know that other people believe more in, if you like, neural toxicity from other mechanisms. I don't tend to hold that view, but I acknowledge that that's a view that one can potentially hold. Yeah.
Bill, I think you showed that there's a beautiful, kind of video from you could see the exoplasmic flow in the mitochondria. They were kind of shooting back and forth.
Yes.
And in your histology also, you showed that a specific strain for the metabolism happening in the lamina area, where you showed that the pressure is high, kind of metabolic activity is more. What is the kind of a pressure? Is there any pressure limit there, like any threshold pressure that beyond that, there's a stasis of the external flow, and under that we are relatively protected? Is there any particular?
We haven't seen that. About 4 or 5 different groups in the 1970s and 80s did a lot of that work using radiographic traces and also dye traces. They didn't publish a set threshold, but it appears that it's more a graded response, where you get probably some nerves are tougher than others in the sense of being able to transport material at high gradients, whereas other nerves are unable to do that, other nerve fibers rather. So it seems to be a graded response, not an all or nothing response for the individual axon. So the axons vary in their diameter. They also vary in terms of their cytoskeletal content. So one thing that may be of importance is the quality of the mitochondria, which is partially hereditary as well. So and the reason for showing that video is that it's almost like the mitochondria are being delivered to regions where they're needed, where the energy demand is higher. And if they can't get there, then clearly there's going to be a problem in those regions. Also, there's probably a limit to the density of mitochondria that can be achieved in any particular region of the nerve. So there's a whole lot of probably interesting physiological factors at play here.
Any other questions?
Can we take a question from the audience?
Yes, sure.
So we have about 400 people who were listening to your talk, and one very relevant question here is, how will intraocular pressure changes during phacoemulsification impact the lamina in the light of these hypotheses?
Yeah, very interesting question. It probably doesn't have much impact because the time course is very short, that you're getting surges in flow and fairly high pressures. But in fact, there's a fellow in the United States who's put transducers in monkeys' eyes, and just changing posture, so bending over to pick up objects off the ground, for example, will elevate your intraocular pressure a lot. So even through daily life, we're getting surges in pressure, irrespective of whether we're having phaco or not. So those short-term changes in pressure don't seem to have much effect.
Any other question from the panel?
Just one. Yes, Dr. Naik here again, which is not related to this talk, but since he is interested in glaucoma, are you envisaging any or involved with any pharmacological agent which can have some in future potential for neuroprotection?
Right. Yeah, good question. We were part of a very large memantine trial about 10 years ago, which looked at glutamate nerve toxicity. Unfortunately, that trial, which ran for 5 years, it was very well conducted, multi-center international trial did not show any benefit at all between the control group and the group having memantine. So that was the first neuroprotection drug trial that was ever performed, and it showed no benefit. Now, there have been none performed since. There've only been anecdotal reports. So at the moment, I think it's impossible to say. The evidence is not strong based upon that trial. The only drug I use occasionally for a supposed non-pressure effect is actually betaxolol, which has a significant calcium channel blocking effect, and that effect does reach the retinal vessels. I use it sometimes in patients with very severe glaucoma who have got very low pressures with the aim of trying to improve their blood flow to the optic nerve. But it's very anecdotal and I don't have any proof. So, and I would have to say that's probably the way for everyone who currently uses a drug supposedly for neuroprotective effect.
Dr. Rakesh, you wanted to say something? Dr. Rakesh?
Yeah. Dr. Rakesh, unmute yourself.
Yeah. Thank you, ma'am, and Pandav sir, and I accept to be here. And this is the unique thing for me, this the intracranial pressure. So I want to know what the relation between the intracranial pressure and normal tension glaucoma. So the hypothesis behind this, I saw in the literature that the reduced intracranial pressure can cause the development of the normal tension glaucoma. So what is the exact hypothesis behind this, sir?
Oh, yeah, that's a very good question. So it's directly related to our research, so that if you have low CSF pressure or low intracranial pressure, it will heighten the gradient. So remember those curves, it will heighten the translaminar pressure gradient, assuming that the buffering effects remain constant. So that's the reason why it's predicted that having a low CSF pressure will increase the chances of having normal tension glaucoma, because it will amplify or increase the pressure gradient. Now, the fact that you have these buffering factors of the pia mater and the orbital pressure does complicate that equation a little bit, but that's in essence the reason why.
Yes.
You wanted to say something?
Yeah, good morning, Dr. Morgan. Good to see you again.
Hi, Shushmita. I remember, yeah.
So I had a question. There's been a lot about corneal hysteresis being related to the deformability of the lamina. And since we do have the ORA, which gives us hysteresis values, in relation to your experimental work, have you seen any direct correlation between the two, or if you've done something?
No, the short answer is I have not seen any direct relationship. We haven't applied that in our work, so I can't speak from personal experience, but I haven't seen any correlation of significance between corneal hysteresis or corneal thickness and actually, there may be a small relationship between corneal thickness and laminar thickness, but I'm pretty sure Josh Jonas published on that and could find no correlation at all. So that was when a lot of the information came out about corneal thickness and its relationship to likelihood of getting glaucoma. That was one of the first theories, but I'm pretty sure Josh Jonas published quite a nice paper on that where he looked at that in depth and could not find a relationship. So most people, I'm assuming, and the later work has really concentrated on the effect of corneal thickness in terms of how it alters the true intraocular pressure compared to the measured value, really, rather than any possible linkage with the lamina. Again, it's in terms of the laminar mechanical properties, laminar compliance, we did try doing some early work on laminar compliance with OCT, ophthalmodynamometry, but it's actually very difficult and you have to make a lot of assumptions. So I wasn't sufficiently confident of our results to publish those, and I haven't seen any really good results in terms of measuring laminar compliance. So what I mean by laminar compliance is the laminar volume versus pressure relationship. So I don't think it's possible yet to say whether corneal hysteresis is related to laminar compliance or mechanical properties.
But Bill, if I remember, you had that ophthalmodynamometer that you developed yourself through which you could do HRT.
Yes.
So
Yeah.
Those experiments.
Yeah, we tried that. We just couldn't get very high quality images, unfortunately. And then we were wondering what we were doing to the orbital pressure by pushing the eyeball backwards into the orbit. And we couldn't control for that either. So I basically stopped doing those experiments. And the other reason being was that we then got more interested in the retinal vein pulsation characteristics, which we could more easily measure with that technique.
Any other question? Dr. Chandra?
Dr. Sati.
Yeah.
I just wanted to know if there is any change in the way we would use prostaglandin analogs going by your work with what happens in the orbital pressure. Would you suggest any kind of changes at all? Because right now it's first line, and do you anything clinically that?
Yeah, I feel, look, I don't have any proof. It's only a hypothesis. So I probably almost should not be saying this really without any evidence. But it disturbs me a little bit, particularly if younger people are put on a prostaglandin, which causes a lot of orbital atrophy. I'm just wondering what they're going to be like when they hit 60 or 70, or whether that's going to be good for their glaucoma. So my first line treatment is typically latanoprost or travatan. I don't find that they cause very much orbital atrophy. If I'm really worried about that in a very young patient, I will try timolol. If they don't, I will use timolol. But it means that I tend to avoid bimatoprost unless they're quite elderly already. I figure if they're already elderly, then they've probably only got, depends on how long you think they're going to live for, but I tend to limit my use of bimatoprost to the elderly. But as I said, I don't have evidence for this, and it's not a recommendation I would necessarily make. It's more that what I was really saying is that the orbit probably is important as a buffering factor for the CSF pressure effects, and that one can see changes in the orbit with age, but also with some drugs, and that there may be some effect there, but we just don't know, unfortunately.
Dr. Chandra, do you have anything in the chat? Any questions?
Yes. So can we move on a little bit to the Zen implant?
Oh, right.
The area of curiosity. You're here with us. And so we'd like to know that the Zen gelatin implant, how does it A, compare with trabeculectomy? And B, is that what is the pressure range that you are looking at where you could actually use the Zen gel implant?
Yeah, okay. The Zen, to get a good understanding, I'd need to have another hour and present to you our findings from the original studies we did with the Zen, both the animals and the humans. So we're involved, we actually developed the Zen, and then we were involved with the original phase 1 FDA trials. And at that time, we were using a gelatin stent that was thicker. So the external diameter was about 240 microns and the internal diameter was 120 microns. And those patients, so just remember that the wall thickness of the stent was about 50 microns. We've now followed those patients for 10 years, and they're just starting to fail at about 9 or 10 years, those patients, for various reasons. Now, the current Zen is the Zen 45, which has an outer diameter of 90 microns, inner diameter of 45, exactly the same length. It's it's the same material as well. And the longest time I think they've been in for anywhere in the world would be about 5 years. We've been using them, I've been using them here in Australia commercially since about 2017, which is when we got access to them. So we have 4 years, only 4 years of follow-up data. So I'm telling my patients that I would expect them to work for about 5 years, possibly out to 9 or 10 years, bearing in mind that they're thinner than the original Zens. Now, what our initial results, and we are trying to publish this, that the initial results over the first 2 years are roughly equivalent to a trabeculectomy in our experience. But we have a different population cohort, mainly Caucasian patients. So I have operated on several people from South Asia, so India, Pakistan, Ceylon origin, Sri Lanka origin. And we have had some good results as well. But our cohort is different, so it's a little bit hard to necessarily compare. It's definitely that there are less complications than with trabeculectomy. Patients recover faster, and we've analysed the data. I think the average follow-up for this particular work we're writing up now is 2 years, so roughly equivalent to a trabeculectomy. But they tend to require more post-operative management and more, I would say, more 5-fluorouracil needling. There's a slight tendency for the smaller stent to become blocked more easily, and they can become blocked internally. We're seeing material from within the eye, and it's not just pseudoexfoliative material, but other material that we hadn't seen before, produced by the eye, blocking these stents sometimes. And there is a tendency for fibrosis at the back end of the stent. So I think if you're doing them, you can expect to have to follow them more closely for the first 6 months and make sure that the bleb is functioning well with 5-fluorouracil injections in at least a half of the patients in our experience, perhaps slightly more than half, maybe 60%. They generally are happier than the ones who've had a trabeculectomy, but we haven't followed them for more than 4 years. That's a long-winded answer to your question. I'm hoping it answers the question that your participant was really asking.
I'm sure it does, yeah, because trabeculectomy also will look at a 2 to 4 year follow-up to see the best results, following which we do expect that the results are going to wane. So it does compare well with the trabeculectomy. The other question, I'll take one more question and then we'll move on to the panel, is that would you use it in angle closure?
That's a good question. Not with, well, personally, I don't do a drainage procedure and angle closure without the lens being removed in most cases, especially if there are signs of ciliary block. So the short answer is no, but I do them in patients who are pseudophakic, who've had angle closure, and have done them in patients with a lot of residual synechia as well. We haven't got enough data, but my impression is that those results are not as good as the open angle results. And I don't quite know why that is. So in some patients with residual angle closure or where there are synechiae, a lot of synechiae, I may do a trabeculectomy instead of doing a Zen implant. So I think one should be careful. If you were starting out doing Zens, I would stick to primary open angle glaucoma, particularly in patients who are pseudophakic. I think you'll find that you'll get a better handle on the operation and you'll get better results. It'll give you more confidence about what's happening. I think that you're more likely to get failure if you're doing patients who have got residual synechia. So patients who have got appositional closure only, then I'll do a Zen combined with a cataract. So I'll do a phaco Zen basically in those patients. But if they have a lot of synechia I think twice about doing it.
Thank you. I think, Dr. Chandran, we are off time already quite a bit.
Yes.
The last question, Bill, before I'll bring it back to you again to the pressure gradient per millimeter of the tissue that you talked about. I think what I understood by that, if CSF pressure is 0 and if intraocular pressure is somewhere around 15 millimeters of mercury, the gradient is about 33 millimeters of mercury per millimeter of the tissue, right?
Yes.
So, and if this gradient goes to like 40 millimeters of mercury, so, or 45 millimeters of mercury, probably we are in an uncomfortable zone as far as glaucoma is concerned. Is that right? So, how do you, I mean, does that impact the treatment of ocular hypertension, for instance? Because going by these figures, anytime we have an IOP of 25 millimeters of mercury and CSF of 0 millimeters of mercury, so the gradient per millimeter of the tissue is well beyond that limit. It would be 45 millimeters of mercury or more if it's right correctly. So that would make us kind of uncomfortable if you leave ocular hypertension untreated, if the IOP is 25 millimeters of mercury or more.
Yeah, so that's a great question. I'm just going to step back a bit. So that figure of 45 millimeters of mercury per millimeter comes from one paper published in the 1980s, I think, by a fellow called Hanenberger from Denmark, using rabbit sciatic nerve and trying to establish a pressure gradient across that rabbit nerve using some rather crude fluidic. So, and it wasn't clear whether he actually got that pressure gradient that I mentioned that was quoted in the literature. So one would have to actually, it's like many things, when you start reading down into the detail, you realize it's not quite so clear cut. But definitely there is some pressure gradient threshold at which you're getting more inhibition of axonal transport, and this is what they found, and it fits other observations as well. So it may not be all, and the other thing is that in a given individual, some individuals may tolerate a higher gradient than others because of the health of their mitochondria or their cytoskeletal health, etc. So I wouldn't necessarily hang my hat on that figure, for example, but it's probably around about that figure. So, and then the other thing is that we don't know, we can't measure the laminar thickness in an individual yet. So we don't necessarily know what an individual's pressure gradient is. So it's really hard to tell. But I think it adds, if we were able to measure laminar thickness accurately, then we could also track whether the lamina is starting to become thinned. Claude Burgoyne's work with the monkeys was very interesting in that the first thing they saw when they elevated intraocular pressure in their monkeys, their artificial glaucoma monkeys, was actually an expansion of the lamina. And there's reasons for that. It's probably got to do with the lamina being a confined space, or it's a bit like the orthopedic injuries where you get a confined space or compartment syndrome in the lamina. So they first saw some slight expansion of the lamina, and then it started to compress after that and shift backward. So in the next 10 or 15 years, if OCT scanning improves sufficiently, we may actually be able to identify some of those changes. So that's what I would be wishing for. In terms of wondering whether an individual's got too high an intraocular pressure, I think we still have to go by our current gestalt, where we factor in the family history, if they're likely to have a thin or a weaker lamina, if they're high myopes, etc., and then make a guess at where we feel comfortable about their intraocular pressure. I think we're still really at that stage, unfortunately, Surinder.
Thank you, Bill. I think you have given us a lot of your time, and we have actually exceeded almost half an hour by our usual time frame. So that only indicates there's so much of interest in in the kind of work you have been doing, and I think everyone realizes the importance of all those findings. Are there any last minute questions? Just one question if there's any.
No, if the panelists want to ask something, Dr. Mayuri or anybody else?
So I think we have traveled Bill a lot already, so we will not take any
Yes.
questions, and I think we'll probably close the discussion here. With us, thank you, Bill, for sparing your time with us, and it was wonderful listening to you. And I hope you'll come back soon, virtually or physically. We hope in the coming months, coming years, and it'll be great to catch up with you again. Over to you, Chandrama, for your last,
Thank you. Thank you very much, Dr. Pandav, and thank you very much, Professor Morgan, because it was wonderful listening to you, and we really enjoyed the entire session. Thank you for being a part of the GSI webinar, and we look forward to having you physically sometime in the future. And I want to thank the expert panel. Thank you very much for joining us this morning, and your inputs have gone a long way to bring home the audience a lot of what Dr. Morgan talked about. Thank you very much once again, each one of you. Thank you. Thank you very much, and have a wonderful Sunday. Thank you very much.
Thank you.
Thank you very much.
Thank you.
Thank you.
Sir. Thank you, ma'am.
Bye-bye.
Thank you, sir.